Good day. Today's session is on intestinal amebiasis. Now, there are some questions in your competitive exams, but of course, if you're giving your exams like your fellowship exams, your MRCS, FRCS, they may not ask much about amebiasis. But for the students who are from the Asian subcontinent watching this in Southeast Asia, this will be very helpful because the incidence is quite high in these areas. So coming to intestinal amebiasis, this is my claimer or disclaimer slide, and I have a Telegram channel. The moment a YouTube video is uploaded, invariably questions will be asked, will be put in the Telegram channel also. So I do request you to join the channel. Now, what are the species? It's a eukaryote. That means it's got a nucleus. It belongs to the phylum Amebozoa and the class, and the genus will be Entamoeba. You have a whole lot of species, out of which Entamoeba histolytica is what is our clinical interest. You have Entamoeba coli, but then it is a very harmless pathogen, commensal living in the intestine. So it's the most common pathogenic amoeba in man, and coli is a harmless commensal in the intestine. These entamoeba cells are small with a single nucleus. That's why you call it a prokaryote. And typical pseudopods. And it has a very simple life cycle. It does not have to go and, find maturity or have the sexual cycle, some other organism. It's a very simple life cycle. The trophozoite, which is the feeding and the dividing form, is 10 to 20 micron and feeds primarily on bacteria. It has a simple binary fission. Almost all the species will form cis except Entamoeba gigivalis. Anyway, that we are not worried about. It doesn't come under clinical species. Now, depending on the species, they can have 1, 4, 8 nuclei. This is for core microbiology. As a clinician, we are only interested in Entamoeba histolytica. So, you can see here the detailed pseudopod, single nucleus, and other stuff. So, the causative agent is Entamoeba histolytica. And you can see this is an enlarged diagram. The presence is of the pseudopodia. And it lacks a mitochondria. As I told you, very simple cell cycle. Suppose the cyst entered the man. It will undergo something known as excistation. It will form trophozoites. These trophozoites will nicely multiply and then become cysts again to exit the host. It's very simple. So that is the cyst, how it looks under the microscope. This is how the trophozoites will look. Now, both these can be found in your stool specimen. But this line diagram, I wanted to tell you how it looks on the under the microscope or in real time. So let's look at the cyst. The cyst is the infective stage. It can survive for weeks if appropriate environment. The infective dose can be a single cyst also. So whom do you call a carrier? Somebody who's having 1.5 to the 10 power 7 cysts per day. They are called carriers. And the reservoir is only human and it can go on for years. Your trophozoite is not an infective stage. Your trophozoite is a disease-causing stage in the human being, but it's not the infective stage. You need to know this particular difference and the carrier state. Now, is it resistant to chlorine in normal concentration? Yes, but it's readily killed by freezing or heating. So you boil water for drinking. Now, what is amebiasis? It is harboring of protozoa inside the body with or even without a disease. You may not be symptomatic for it, but it is still amebiasis. 10% of the infected only they develop a disease. So they are walking around with these entamoeba inside, but they don't develop a disease. In the intestinal manifestation, it can be mild to fulminant and even death. Whereas extraintestinal, yes, you will have in the liver, skin. They are all amoebic liver abscesses. What is the problem? It is worldwide in distribution, except in countries which are very well developed. It's a third most common parasitic death. Malaria leads first, especially in China, India, and 2 to 6% prevalence. 60% prevalence is almost the whole population, and about 10 lakh deaths per year. This is global. In India, there is a 15% prevalence, and it depends according to the area sanitation. So what about trends of amebiasis? You see that they are quite high in Africa and America as well as India, and very, very low in rest of the world. So it's caused by Entamoeba histolytica. The majority remain asymptomatic carriers. Amoebic liver abscess, which is the most common extraintestinal manifestation, occurs in less than 10% of the infected population and in endemic areas, and it is much more common than a pyogenic liver abscess. So most of the abscesses that you find in India without a pre-existing biliary pathology like a stone or a malignancy involving the CBD. If there is a liver abscess, 90% of the time it's an amoebic liver abscess more than a pyogenic abscess. In fact, I have taken a presentation on amoebic liver abscess where I mentioned the difference between amoebic and pyogenic. You can probably revisit it. As I told you, it's a very, very simple cycle. Mature cysts from somebody or from himself, they enter the GI tract. They go down. What happens in the small intestine? They become trophozoites. Then they go and get washed into the large intestine. Now these trophozoites can just get washed out, and they'll be making cysts there, and that will get washed out. For some reason, the virulence becomes high, or the immune capacity of the host becomes less. They will start invading the colonic walls. Now, when they invade the colonic walls, they will call the intestinal amoebic dysentery or acute amoebic or chronic amoebic dysentery. Now, not only that, they can invade, go through the wall through and through. The trophozoites have their own mechanism of handling the body defense, and they can lodge in the liver, which will be a first site of area where they lodge. That's because all the way blood is going through the portal vein. They will lodge in the liver and form liver abscess. Or they can somehow find their way into the systemic circulation. They can form a lung abscess, a brain abscess, or even abscesses in the skin. So this is important. Now the organism enters through food or water. And as you know, this is the rest of the sequence. So it doesn't have any reservoir there. Man is the only reservoir. He may be a reservoir to himself, or he may be a reservoir to another human being. But it's a very close, small cycle. Modes, of course, contaminated water and food, or direct hand to mouth, then agencies and sexual contact via oral and rectal contact. What are the risk factors? Poor sanitary conditions, immigrants who are coming from developing countries, travelers going to developing countries, poor sanitary conditions, HIV positives and homosexuals. Because you know the route of transmission and the endemicity, you realize that these sentences or these statements can bring clarity now. So all age groups are affected. Again, it's the same thing. It's severe if in children or old and pregnant. Once there is tissue invasion, they develop antibodies. Environment, again, it's the same thing. So it's something very simple again. Again, I'm coming back to this particular diagram because this part, if you understand, you will know what to find in stool. You will know what is amoebic manifestations inside the intestine. What are the extra-intestinal manifestations of amebiasis? So now let's have a look. They can be just plain carriers, or it can evade the intestinal wall and become symptomatic with an amoebic dysentery. Or they can go one step further and go into the liver, into the lungs and the brains. So they can be in a carrier state, the trophozoites, and they are forming cysts and just sitting there. They can become symptomatic for the intestine. They can break through and go to the other organs also. So in the humans, they stay in the mucous gel layer. Then what do? They try to penetrate. They have their own mechanisms how they can penetrate. The virulence or the load will go up, they will penetrate. Once they penetrate, you have the defense mechanisms to take care of them. Now, just taking care of them is not going to help. There is a fallout for these defense reactions. A whole lot of inflammatory molecules are released that will lead to diarrhea, and maybe these will get cleared also, and of course apart from help from outside in the form of pharmacology. Sometimes this infection here and this reaction here can go totally haywire and become so fulminant, maybe leading to a surgical emergency. It may be ending up in a surgical emergency, needing emergency laparotomy, or even so fulminant that it can lead to death. What are the virulence factors? They interact with the host through steps. Both humoral and cell-mediated response are there. As I told you, they may be just carrier states. Causes disease only when they invade the intestine. And by what? By cysteine protease. This is the most important trump card that the trophocytes have to break the barriers. As I told you, there can be some contribution factors like especially alcoholism. Now, what is the incubation period? If the amount of cysts entering is very high, it can manifest in 3 days itself. Several months in subacute and chronic form, but in the average, it's about 3 to 4 weeks. This is important when you're taking travel history. Period of communicability is for duration of the illness. Extraintestinal amebiasis. It enters the portal venous system, causes infarction of the hepatocytes. In fact, there is a detailed presentation in one of the in the YouTube itself. I will share the link. Now, the areas of necrosis will eventually coalesce. They form small infarcts, but then they will ultimately collapse and form one single cavity. That's why you're able to easily aspirate them out. Now, invasive versus non-invasive strains. Invasive strains is histolytica, but Dispar and coli do not invade. That you have to keep in mind. You might find these cysts in the stool sample. They have their own characteristics, but they are not invasive species. And the antigens will be different. So clinical features, as I told, asymptomatic carriers, 90 of them, they may be just asymptomatic. They may not even be in the carrier state. You must understand that asymptomatic is not the same as carrier state. Amoebic colitis can be acute, which can be just mild, moderate, and even fulminant, or it can be chronic. And you can have something known as amoeboma. I particularly made this presentation to stress on this amoeboma. Extraintestinal, they are abscesses in these following organs. So 90% will be roaming around without symptoms and they do not even damage the lumen. Symptoms of amoebic colitis, 100% will have diarrhea. When it is colitis, we are not talking about amoeboma. May or may not have mucus discharge or diarrhea. But when we are talking about colitis, 100% will have diarrhea and a large number will have dysentery itself. Of course, abdominal pain and other things. So what are the clinical manifestations? Acute amoebic dysentery, there is a slight attack of diarrhea, altered with periods of constipation and accompanied by tenesmus. And foul smelling stool, nausea, flatulence, abdominal distension, etc. And they may have tenderness in the right iliac fossa over the colon. So your main thing is to differentiate bacillary dysentery from amoebic dysentery on clinical grounds and then of course on the lab support investigations. So a bacillary dysentery is acute, 1 or 2 days, but amoebic dysentery is not usually acute. They will say about a week. General condition will be very poor in bacillary dysentery. This is very important. It's a big clinical clue, whereas it will be normal. Fever will be high grade, another clinical clue. Then tenesmus, that is feeling of inadequate evacuation, will be very severe in bacillary dysentery. Dehydration is very common because it's a serious issue. In the feces, you will not find trophozoites. Here you will find trophozoites and culture, stool culture will be positive for Shigella and Salmonella. It will be negative for Shigella and Salmonella. In the outpatient itself, you can do a sigmoidoscopy. If the patient complains of bloody mucus diarrhea, the ulcers occur in the rectosigmoid and they are easily within reach of the sigmoid scope and they are shallow skip lesions. Undermined ulcers may be seen and they can be biopsied or scrapings can be sent. The presence of trophozoites distinguishes the condition from ulcerative colitis. You see the other things twining. Ulcerative colitis in the very beginning, you may have very shallow ulcers and with diarrhea. Very difficult to differentiate. So in your sigmoidoscopy, take a scraping and you find trophozoite, you are 100% sure that it is amoebic dysentery. In the macroscopic, you won't find flash-shaped ulcers. I find this mistake, people trick you. In the MCQs, I've seen this often. They'll say flash-shaped ulcers on endoscopy and they'll go and tick it. So be careful. On endoscopy, it will be only shallow ulcers. And that too, they will be, they may not even be confluent. You'll get an ulcer here, some other ulcer there, one there. They may not be confluent. But flash shape, you will not see on endoscopy. And when you do scrapings, you might find cysts and trophozoites. You might find both. Chronic amoebic dysentery is accompanied by tenesmus, weight loss, anorexia, liver may be enlarged, vague abdominal distress, flatulence, irregularity of bowel, and a whole lot of other non-specific colonic symptoms. Now, microscopic examination has to be done immediately before the specimen cools down. So you take fresh mucus or a rectal swab. You will get colorless motile trophozoites with ingested RBCs and you will get quadrinucleated cysts. That's how you know the difference between Entamoeba histolytica and Entamoeba dispar, because those two are commensals. If they are sitting there, they are not the cause for the problem. You will be able to make out from the architecture of the cyst and then you may do a serology with your other serological tests. Serological tests are more specific, with majority of patients showing antibodies in the serum. They can be diagnosed by various serological tests. They are useful in detecting acute infection in non-endemic areas. If it is endemic, anyway, you will find antibodies in that person. So in non-endemic areas, if they are suspecting amebiasis, instead of doing a sigmoidoscopy, which is done, it's easy, but then it's much more troublesome to the patient than just drawing a blood sample. It has a very high sensitivity rate in amoebic liver abscess in non-endemic regions and remains elevated for some time. The persistence of antibodies in a large majority of the population in endemic areas, you cannot use it for your day-to-day working diagnosis in endemic areas. And then you need more refined immunological tests in these settings. What are the investigations? You might find these non-specific investigations, which are definitely not specific for amebiasis, but for a chronic problem. So, as we said, 90% can be asymptomatic carriers. Now, where do we treat? Do we treat the whole population of India and the world? No. You will offer treatment in symptomatic cases. Somebody with amoeba, dysentery, liver abscess. Asymptomatic in non-endemic areas. Suppose they are in a developed country. For some reason, you have done a stool examination as a master health checkup, or you have done a colonoscopy, whatever. They are still asymptomatic, but you still need to treat them. And in asymptomatic, if food handlers, wherever they are, you need to, whether it is in an endemic part of the world or non-endemic, you need to treat them. So you must know where exactly to, or where are the indications to treat using anti-amebicidal drugs. So what are the drugs? Metronidazole, tinidazole. I'm not going to go into the pharmacology. Where does it act? It kills trophozoites in the intestine and tissue. This is the infective, this is the disease-producing stage. The dose, you know this. It also kills trophozoites in the intestine and tissue, and you give this dose. Now, you must always give a luminal amebicide. It has to eradicate the cyst. And that has to be given after this course is over. This is very important. Sequencing the anti-amebicide drugs is important because your patients will not show compliance. That is very important. Or you can give the dilonazide furovate, which is also for 10 days. Fulminant colitis can be really severe with a high fever, intestinal bleeding, perforation, and even a paralytic ileus. You have to sometimes end up removing the colon itself because they will go into, they would have already this as perforated. You can have severe hemorrhage from these ulcers. Then what you can do is you have to resect that part, or maybe you can try interventional radiology, see whether it is a single bleeder, whether it is feasible to embolize, or there may be multiple ulcers bleeding. Interventional radiology may not work and you'll be forced to remove that part of the wall. So it's a general principles of surgical emergency. You have to resect, you have to resuscitate followed by resection. Then the patient is given very vigorous anti-amebicidal and supportive therapy because it has become a surgical emergency now. Now there's something known as an ameboma. Apart from amoebic, apart from asymptomatic state, apart from colitis, which can be acute and chronic, in the acute you can have mild, moderate, and even fulminant, and then you can have something known as an ameboma and the extraintestinal sites. This is a chronic granuloma arising in the large bowel, most commonly seen in the cecum. It is prone to occur in long-standing infection that has been treated intermittently with drugs without completion of a full course. 1% of cases inflammatory thickening of the intestine and a palpable mass which on histopathological examination will reveal trophozoites. Now, 30 years back, every right iliac fossa mass, a DD was always an amoeboma. Now, we are not bringing in the DD at all. We are only thinking about TB and CSC in a right iliac fossa mass or an appendicular mass. But we never bring in amoeboma. 30 years ago, this was very common. Amoeboma was one of the DDs. Let's look at one of our recent cases. This is from Pondicherry Institute of Medical Sciences. Thomas Alexander sir is the gastroenterologist, medical gastroenterologist. They had a right iliac fossa mass for which a colonoscopy was ordered. You see, that was clinically they had a mass. A CT was done. You can see a mass here. Now, when there is a right iliac fossa mass, you don't straight away put a colonoscope because the mass can be from a lymph node. It can be from any other structure here. Why do a colonoscopy which can be quite unpleasant to the patient? Localize where it belongs to on your CT. So when they did a CT, they realized it belongs to the colon and then they have done a colonoscopy. That's how you should be able to sequence. Sequencing is very important. You might have 10 investigations at your disposal, but sequencing is the game changer there. So when a colonoscopy was done, you find shallow ulcers. See, very shallow ulcers all over. This is not normal colonic mucosa. And a biopsy revealed a typical flask-shaped ulcer. So when they say flask-shaped ulcer, it is in the histopathology of an amoebic ulcer and not a colonoscopic finding. So on that histopathology, they found trophozoites. This is from Pondicherry Institute of Medical Sciences. So they found trophozoites and confirmed it is an amoeboma. Then naturally you will start the treatment accordingly. Now there is a catch. As I told you, this can be mistaken for a carcinoma. Now, if a patient from an endemic area is coming with generalized ill health and pyrexia and a bloodstained mucoid diarrhea, you think of an amoeboma. Because carcinoma, for it to have diarrhea is difficult. They may be losing blood. Occult blood they will lose. Left side colon they will come with constipation. But to come with the diarrhea as such, it's a little unlikely. But nothing is 100%. You need supportive investigations and you need to think beyond the DDs. So a colonoscopy and biopsy are mandatory. Now, even if doubtful, vigorous medical treatment is given. And again, you can recheck within 3 to 4 weeks. Don't waste time. If symptoms persist, you have to rule out a colonic carcinoma. You can decide to take a repeat biopsy. But you must always also keep in mind that both can coexist. We had one particular case which was repeatedly coming negative for amebiasis. What we did, we went ahead, we said no, we need to be careful, and we removed the part of that bowel. And it came as malignancy. So these things are important. They can be together. Things may be totally, on the surface. You may not know whether this is malignancy or an amoebic process. There'll be repeatedly patients will come to you, or what will happen? They did not get a quick response. They will move to some other facility and start from ground zero. So the process is repeating for the patient hundreds of times. Nobody looks at the patient as, no, he's gone 3-4 times. There is an issue. We need to look beyond what the first facility had seen. No, they will start again from ground zero. And this is a vicious circle. But what I'm telling you is, if the thing is lingering, there is no obvious, you did not find flask-shaped ulcers, biopsy was not adequate, you did not find trophozoites, your antigen testing, your antibody testing in your endemic area is not going to give you any sort of clue. You will be forced to go and remove the specimen. Now this specimen came as CA, but it could have also come as again ameboma. It's good for the patient. At least you were able to come to a diagnosis. Whether it's a cancer or a ameboma, you came to a diagnosis at least. So prevention has a major role in reducing the disease burden. As I told you about sanitation, water, food hygiene, and your education should be long term. What is secondary prevention? Early diagnosis and treatment. Somebody comes to you with diarrhea. Yes, you will, and the OPD you will be giving anti-amebicidals or some bactericidal agent, whatever. But if they are repeatedly coming to you, then you need to get to the core of the matter and start the appropriate treatment. Extraintestinal amebiasis. This is a patient who's had a liver abscess. As I told you, they will form small, you see here, they will form small or large abscesses or abscesses which are not in continuity. There is one more here. Finally, the liquefactic necrosis will set in so well, it will sort of coalesce. The liquefactive necrosis will all join together and form one huge cavity. And that cavity you will be able to drain under ultrasound guidance. You can see the anchovy-sauce pus. There is a separate presentation on liver abscess. I will be sharing the link, please, in the end cards. Please have a look at that site also. That is more clinical oriented. I won't be talking much about the life cycle of the parasite. So thank you. And please go to my Telegram channel also. I will be posting MCQs on amebiasis. I've posted some MCQs on amoebic liver abscess, but this time will be intestinal amebiasis. And please share and like my YouTube channel. Particular thanks to my students from Indonesia. They had put some very nice encouraging comments in the YouTube presentation. And most of them had written in the Malay language. I did not know, and neither could Google Translate very well. So I had to find somebody who will translate it for me. And they were all very encouraging comments. Thank you all so much. Keep the comments coming. At the same time, please keep the doubts also coming. Thank you very much.